Good afternoon, everyone. My name is Brittany Card, and I'm a visiting fellow at the Center for Human Rights and Humanitarian Studies at Brown University. On behalf of the center, thank you all for joining us today. A housekeeping note, all participants are muted, so please submit your questions throughout the presentation using the Q&A function. We are excited to host Professor Len Rubenstein for a discussion on the drivers of violence against healthcare and war. Len Rubenstein is a professor of practice at the Johns Hopkins Bloomberg School of Public Health and is director of the program in Human Rights, Health, and Conflict. He is also a core faculty member at the Berman Institute of Bioethics and the Center for Humanitarian Health at Johns Hopkins University. Professor Rubenstein's work focuses on human rights, health, and armed conflict. He has done extensive research on the impacts of conflict on health in Syria, the West Bank, Gaza, Afghanistan, and other parts of the world. We are lucky to have him here with us today, and I will now turn it over to you, Professor Rubenstein.
Thank you so much, Brittany. It's really a privilege to be with you at the Watson Institute and the Center for Human Rights and Humanitarian Studies. Adam Levine and colleagues have provided wonderful leadership in providing and uniting these two fields in innovative and important ways. I'd like to go back 25 years to 1996. It was my first encounter with violence against healthcare. I had just become director of Physicians for Human Rights after a career in US-based civil rights advocacy. I went to Sarajevo to release a report my predecessor had written about violence against healthcare in the war in former Yugoslavia. The war had been over for 9 months, but the evidence of destruction was everywhere. Even the large Holiday Inn remained covered with the ubiquitous blue sheeting that covered blown out windows all over the city. One of the stories in the report was about Dr. Esma Zezovic, the chief pediatrician at the country's main pediatric hospital, on the left of the slide. On May 26, 1992, at 4 o'clock in the afternoon, Serb forces shelled the city from the surrounding hills and hit the hospital. There were 17 premature infants in incubators in the neonatal wards. She later wrote, quote, "Each of us carried 2 or 3 babies and ran to the basement of the obstetric and gynecological hospital. Bullets and shells fell all around us as we were carrying the children," unquote. Initially, they were lucky. 5 minutes after the staff got all the children out, a shell hit the neonatal unit, destroying the incubators and incinerating the unit. Soon afterward, the neighboring obstetric and gynecological hospital where they had escaped was shelled, and the floors above them began to collapse. They survived, or many of them did, the night, frightening night it was, without light, supplemental oxygen, or water. But 9 of the babies died. In the morning, trucks and cars evacuated survivors to the large Kosovo hospital in the city, which you see on the right. But it was shelled then and later, and you can see the impact of 170 times of shelling in just the next year. The staff managed to keep the hospital open, but suffered shortages of fuel for generators, medical supplies, painkillers, and antibiotics. And broken central heating caused water pipes to freeze during the long winter. They sterilized instruments using a wood stove. Food ran low too, leading to the anomaly of malnutrition inside a hospital. In the follow-up to our report, I was struck by something else. How little attention was being paid to the violence against healthcare. This was the case even as global health issues began to rocket onto the international agenda with massive increases in funding and attention to health systems in low-income countries. The global humanitarian community was beginning to raise the alarm about attacks on aid workers, but it paid little attention to the indigenous doctors and nurses, like those in Kosovo Hospital, who bore most of the brunt of the attacks. And even as social scientists began to crank out sophisticated studies on violence against civilians in civil wars, attacks on healthcare were ignored. In fact, over the past 40 years, an average of less than one research paper per year has been published on attacks on healthcare in war. No UN agency or NGO tracked attacks or sought to address the problem in a serious way. That has changed somewhat in the last decade. Now we have some data and evidence. It really is. In a map we released just last week, you can see there were more than 800 attacks on healthcare in 2020. And that is an underestimation, since most attacks are not reported. And next day, as many of you know, the anniversary of the worst case, Syria, where 600 hospitals have been bombed and shelled, 900 health workers killed. It is all a strategy of war. You can see on this graph that these attacks took place over the entire course of the war, starting at the very beginning in 2011. The lines on the graph just differ by different reporters, but that pattern is extraordinary. The world did very little to try to stop the attacks. The impacts of these attacks around the world are staggering. Health systems are destroyed. Health workers flee. Malnutrition goes untreated. Vaccinations decline. And one result is the global goal to eradicate polio is still unfulfilled. Women fear going to the hospitals to give birth, leading to more home births and more tragedies. Here's just one example of the impacts. Yemen was in a humanitarian crisis before 2015, when the most recent war started. You can see cholera is literally off the charts. In fact, that red line doesn't even look like it's part of the chart. It's not only the largest in the world in the last 5 years, or in the 5-year period, but it's 2 million cases, which were the product of the bombing of water and sanitation infrastructure, is the largest epidemic ever recorded. The trauma the violence inflicts on health workers is also pervasive. We talk a lot in global health about the resilience of health workers in these fraught environments. Many persevere, just as the health workers in the COVID response have. But there's a difference between doctors and nurses staying at their posts in the face of violence and escaping the trauma of the experience. Dozens of health workers in conflicts have told me about the anxiety, depression, despair, despondency they have experienced. They see horrific injuries from primitive and not so primitive explosive weapons. One Syria doctor recalled his own sense of horror from barrel bomb injuries. I saw a mother and daughter whose bodies were blown apart, he said, but their hands were still clasped together. They suffer moral distress too, feeling that without supplies and support to treat these injuries, they feel guilty that they're not able to do the job they were trained to do and which their ethics said they must do. A Syrian health worker told me, "We have been living in this state for many years. Sometimes I think, really, how do I eat, drink, and live? And think about the bombing and the people who died, with the sense that my mind will explode. When a wounded person dies and his family starts weeping for him in the hospital, I feel guilty. Sometimes I feel I killed him because I could not help." And that was 6 years ago. Many of these health workers have continued to work since. It wasn't supposed to be this way. The picture you see is a painting of the aftermath of the Battle of Solferino in 1859 by a contemporary French artist. You can see the dead and wounded lying on the field. During the battle, they couldn't be attended to because people could be shot at if they did. It gave rise to the first international convention to protect the wounded and sick in war, and their caregivers, what has become known as the Geneva Convention. The original convention in 1864 was the product of the man on the left. Many of you may recognize Henri Dunant, founder of the International Committee of the Red Cross and the father of the Geneva Convention. Dunant was a Swiss businessman and social reformer. He stumbled upon the battle. Siri just talked to me, sorry. The celebrated, he was a Swiss businessman and social reformer, and he stumbled on the battle, saw the carnage and the suffering, and jumped in to organize help for them. He wrote a book about the battle called The Memory of Solferino, that it was this huge bestseller in Europe and as influential on people's thinking as Uncle Tom's Cabin was in the United States at the time. Dunant hated war, but saw that he couldn't end it. So he tried to make it more humane. His convention was based on the principle of humanity, the idea that we should limit human suffering to the extent we can, especially unnecessary suffering. A wounded enemy, he realized, is a human being first. And as a suffering person, he must be, or she must be, offered medical care as anyone else. The person's affiliations or acts in the war are irrelevant in the face of that suffering when it could be ameliorated. That principle became the foundation of the original Geneva Convention. But Dunant was not the only one thinking about the rules of war at the time. In a remarkable coincidence, across the ocean, at the very same time, the man on the right, Francis Lieber, was as well. Lieber was a Prussian activist who, after coming to the United States, became a public intellectual, editing the Encyclopedia Britannica, befriending Henry Wadsworth Longfellow, collaborating with Alexis de Tocqueville on prison studies, dining with Andrew Jackson. Though he'd seen war and he was wounded in fighting against Napoleon III, he celebrated war as vital to the moral progress of virtuous nations. Still, he saw the need for rules. He became principal drafter of a code for the Union Army in the Civil War, the first such code ever adopted. Abraham Lincoln ordered the code adopted in 1863 on the eve of the Battle of Gettysburg. The code has remained so influential that the Pentagon's Law of War Manual calls it the canonical law of war document for the United States, even if it does not reflect current law. Lieber too paid attention to suffering, but for him, it was not the most important value. There were some absolutes, mostly no gratuitous harm, but otherwise combatants could impose arm on civilians to win a just war and to win it quickly, as he thought that the war to end slavery was. His view is reflected in the quote on this slide about hospitals. Unlike Dunant, for whom protection was an absolute, he wrote that they should be protected as much as the contingencies and necessities of the fight will permit. That concept is military necessity, that otherwise abhorrent acts are permissible to win a just war. Over the next century, Dunant prevailed in the law of war. The 1864 convention applied only to wounded soldiers, but over time, it was expanded to 4 conventions, 2 additional protocols that now include civilians as well as soldiers, applies to civil wars as well as interstate wars, and bans indiscriminate as well as intentional attacks. It's a complex body of law with endless interpretations and applications, but the basic principles applicable to healthcare are quite straightforward. Do not attack the wounded and sick, hospital, ambulance, health workers. Care to the wounded and sick must be provided impartially, based on need alone, regardless of affiliation. Never punish health workers for violation of their ethics. Adhere to principles of distinction, precaution, and proportionality. And even if a facility is misused for military purpose, warning must be given before attack, and efforts must be made to minimize harm. Yet my investigations and those of many others over the past 2 decades have persuaded me that Lieber's ideas continue to influence military operations, both for conventional militaries and for the greatly proliferating number of non-state armed groups in a world where civil wars now dominate armed conflict. That's why, after 2 decades of this work, I have to try to show in my forthcoming book the logics of violently interfering with healthcare that are so influenced by a Lieber-esque form of reasoning. The book represents what I hope is a first step in trying to identify and illuminating those logic. Okay, that's my plug. It comes out in July and you can pre-order on Amazon. The book tries to identify 5 drivers of violence against healthcare. Each has a rationalization, if not a legal justification, that Lieber would recognize to win a war that is seen as just by the combatants and to win it quickly. Each of these 5 logics I'll cover as we go forward. The first is opposition to treating enemies. In the picture, Dr. Hassan Baiev, a Chechen surgeon who struggled to provide wounded people on both sides in terrible wars there 2 decades ago, is treating a man named Shamil Basayev, a notorious Chechen rebel commander who may have been the man most wanted by Russian forces, excuse me. Basayev was severely injured by a landmine during a retreat from a battle, and he arrived in a town where Dr. Baiev was practicing. And Basayev was accompanied by 300 other wounded people, most of them stepping on landmines. In Dr. Baev's small hospital, he saved as many lives as he could. By the end of the 3rd day, exhausted and his hands throbbing from work, he had performed 67 amputations. What you see is an amputation of Basayev's leg. He saved Basayev's life. For this and other grueling work, he was targeted by the Russians for treating an enemy. Ironically, Dr. Baiev was also threatened and came close to being killed by Chechen rebel forces for treating wounded Russians. But he saw his duty to remain impartial. He eventually had to flee, and he made it to the US eventually, where he was granted asylum. Denial of care to enemies has become pervasive in war, as has punishing their caregivers, despite the Geneva Conventions. Hatred and desire for revenge, of course, play a role, but it's not just emotions that drive these attacks. It's not necessarily irrational to deny enemies treatment, especially as is true today, and was true in Chechnya. The wounded combatant is not in custody as a prisoner of war. Rather, they are treated in hospitals or clinics run by aid groups or local ministries of health or health workers. Treatment, however, may allow the person to come back to the fight, also avoid the need to replenish their forces. It may also alleviate the fighting force of having its own health service. but is a logic the Geneva Conventions firmly reject. As the commentaries state, the states have agreed to sacrifice national interests to the dictates of conscience, that is, to the principle of humanity. But the impulse not to treat enemies and punish those who offer it has become common throughout the world. And it extends to communities. This is a picture from Myanmar, a half-century-long war between the military, called the Tatmadaw, and ethnic groups in the eastern parts of the country. Included tactics by the Tatmadaw that involve forced displacement and brutal human rights violations. Considering the entire population as an enemy and anyone who treated them as such, Myanmar denied humanitarian access. In their place, itinerant medics went village to village, well named the Backpack Health Worker Team. They too were treated as enemies for trading enemies. We see this in all kinds of conflicts today. In the Central African Republic, a place with more than a dozen armed groups, fighters enter hospitals to kill patients from religious groups they oppose. Now, we may think that this kind of logic only applies to tyrannical regimes or brutal armies like those of Russia or Myanmar, but the logic has influenced modern counterterrorism policy. The harbingers were in repressive regimes like Serbia and Turkey. On the left is Dr. Şebnem Finkanci, a leading Turkish forensic practitioner at the University of Istanbul. For her work in providing evidence of torture of people belonging to the separatist Kurdistan Workers' Party, she was labeled an enemy of the state. She and dozens of her colleagues have been prosecuted and jailed for reporting honestly about torture or offering rehabilitation. During the 80s and 90s, the State Department Human Rights Bureau condemned acts in Kosovo and Turkey, as well as the treatment of Dr. Bayev in Chechnya. After all, he was granted asylum. That would be unlikely today because in the 1990s, especially after 9/11, the United States led the way in strengthening counterterrorism laws. Those laws, while not specifically designated medical care as a form of material support, excluded. So governments around the world have used these laws to arrest, charge, and even disappear doctors for engaging in clinical care or even intending to do so. As you see from the quote on the right, that's from the US Court of Appeals in a prosecution of a doctor who, as the court said, stood ready to treat wounded mujahideen in Saudi Arabia, which it designated as terrorists. So the act now of providing care according to the principles of humanity and impartiality has been criminalized. This is a logic of liber, not do not. The humanity of the wounded disappears, the protection of impartial care evaporates, and the terrorist label offers a comforting rationalization for dehumanization. Let's move to the second dimension, the second logic. I've already mentioned Syria. Now, strategic targeting, as Syria did, is becoming less common thanks to the Geneva Conventions and the rejection and of the norm that you can do what you want in war. It's also become limited in civil wars, which are the predominant wars today, because armed groups need healthcare for their own wounded. When there is strategic targeting, as in Syria, it's often a pattern of violence against civilians generally, against towns, villages, schools, markets. But the impact on healthcare is obvious. A recent survey of doctors in Syria, or health workers generally, found that 2/3 of them had been in a health facility when it was bombed or shelled. The strategy may be effective. It seems to show civilians the futility and cost of supporting the opposition. It contributes to displacing populations, and it decimates local elites. There is increasing evidence in Syria that attacks on hospitals correlate with military offensive. Let me turn to the third logic, which is known but far more common. It puts aside legal obligations to gain tactical advantage in the moment. This is a picture of the National Hospital in Raqqa, Syria. Its height and location was perfect for machine gun nests, which is exactly what ISIS did during the battle for Raqqa. Even as the hospital remained functioning, the response of coalition forces was to attack the hospital. ISIS also forced or abducted doctors to treat their wounded, very convenient for them. They evicted patients from hospitals to make room for their wounded cadres. They're hardly the only ones. We see tactical gain in all kinds of other actions. Combatants forcing local hospitals and clinics to give priority to their own fighters in violation of normal triage rules, looting medical supplies for their forces, and violently entering hospitals to make arrests. In Afghanistan, tactical interference took another form. In recent years, the Taliban has shown restraint in directing attacks against healthcare, in part because the group is trying to win over the population and show that they can ensure healthcare for them. But for the same reasons, the Taliban manipulates healthcare facilities, demanding control of hiring, services, geographical coverage. They use the threat of violence or even brief abductions of staff to achieve it. I don't know if you can see on the slide because it's very light, but on the top, under the 258 facilities attack, is the number 192 health facilities closed. They were closed not necessarily because of violence, because of threats, and only 34 of them were reopened. Let me turn to the fourth logic, also very common. I call it recklessness and inconvenience, or indifference to taking the steps required by law to protect healthcare from violence. In other words, it's abdication rather than strategy. There are rules now, very clear rules, to say you must distinguish between civilian and military objects in targeting. You must take precautions to avoid harm to civilians. You must facilitate passage of ambulance. And you must obey the principle of proportionality, which requires actions that outlaws actions that be expected to cause death or injury to civilians or damage civilian objects that are excessive in relation to the concrete and direct military advantage anticipated. A difficult standard to apply, but nevertheless an important one. Recklessness or indifference to these obligations is responsible for incalculable harm. Yemen is the most recent and lethal example. Mohammed bin Salman, the defense minister and now crown prince, thought he could use air power to push out the Houthi group, which had taken control of key cities in Yemen and were allied with Iran. He attacked in March 2015. The Obama administration, was skeptical about the plan, went along as an ally, and along with the British and other countries, authorized massive increase in weapon sales to the Saudis and provided military assistance. That assistance, including mid-air refueling that allowed planes to fly, looking around for targets, without the assessments needed to avoid harm. The result was dozens of hospitals on prohibited lists of targets were hit. Thousands of civilians have been killed. At the root was indifference at the highest level of the Saudi government to anything but the appearance of compliance with the law of war, which it claimed to be committed to. Recklessness also applies to the countries that sold arms to the Saudis. They knew their duty was not to allow arms sales. In fact, they should have used their leverage to stop the carnage, but instead obfuscated and disseminated so as not to upset an ally. As two former officials of the Obama National Security Council put it, the United States, and the British as well, quote, got into a car with a reckless driver and never got out of the car. Now, compliance with the precautions and restrictions on targeting takes time, but there's a cost in operational efficiency, but that is no excuse for rationalizing the harm. We've seen this in other contexts, in wars in Gaza, where ambulances have been destroyed during medical evacuation procedures, despite the rules where the ICRC acted as an intermediary to make sure there was safe passage, but no weapons were carried into the conflict zone. ICRC, which is usually silent, in 2002, and this was in the West Bank, when 6 medics were killed in 2 weeks, said they felt betrayed by this trampling on the rules of the Geneva Conventions. Finally, the fifth logic, maybe somewhat surprising, is that the source is community-based groups or self-defense militias, and represent an expression of anger and hostility at government, often as a political expression. We have seen something like this in the violence in the context of COVID. A more stark example is in the Democratic Republic of Congo. An Ebola outbreak there in 2018 took place against a background of government neglect of healthcare, exploitation of political mistrust, corruption, and lack of engagement with communities. The result was violence against responders and health facilities. One of those victims was Dr. Mizuko, a doctor who came from Cameroon, one of hundreds of health workers to try to help the response. He was murdered in a hospital where he worked in Eastern DRC. The question is whether, despite these logic, the perpetrators can be restrained. I believe there's plenty of evidence that there can be. Despite what cynics say, the norms of the conventions are not moribund, nor are the claims that the attacks on healthcare are getting worse justified. There's no more the kind of carpet bombings of cities that characterize the Korean War and the use of napalm across villages in Vietnam. So there are 3 sources of restraint, I believe: internal leadership and implementation of norms in military operations, domestic pressures through constituencies and accountability procedures, and international incentives, pressure, and accountability, including use of diplomatic means. I mentioned Israel before. Let me go back. During the Second Intifada in 2002, where this quote came from, there was a major outcry about the killings of the medics. Many senior military officials were disturbed. The future Ministry of Defense, who was chief of staff at the time, said, I'm worried by the fact that even if we win this war, in the end, we will not be able to look ourselves in the mirror. The Israeli courts weighed in. The combination of an internal belief that by the armed forces that they were disregarding their own norms and a lot of outside pressure led to reform in procedures and soldier training and accountability and the end of the killings. Unfortunately, it didn't last. When the wars in Gaza took place between 2009 and 2015, the political environment changed. More deaths in medical evacuations emerged, less pressures internally, and more resistance to international pressure. There are surprising cases of restraint. I talked about the Taliban before. It wasn't just the desire to give their people health care. They had a code on the left that may be hard to read, but where I've highlighted it, the code addresses healthcare. And they basically say we should not directly attack health clinics. Now, the code was not exactly in compliance with the Geneva Conventions, not by a long shot. It permitted people they considered enemies, including aid workers, to be killed. It also didn't have anything to say about precautions about avoiding harm through clinics and military operations. But it was nevertheless a source of some restraint. At the same time, and this may seem surprising, that the Taliban's conduct has been influenced by human rights reporting. Every quarter, a UN agency reports on civilian casualties. And the Taliban takes it so seriously that they respond to the accusations against them and make new commitments. Not perfect, but it's a start. So where do we go from here? I see three challenges in going forward. The first is the norms themselves. I've mentioned the problem of the erosion of the norm about enemies. But some of the erosion goes beyond that. In the battle for Raqqa, when the coalition forces basically leveled, annihilating the city, Secretary of Defense James Mattis said, "We do everything humanly possible, consistent with military necessity, to avoid civilian casualties at all costs." Sounds like a nice statement, but it's not the standard because it allows military necessity to triumph over avoidance of civilian casualties. In a similar vein, a couple of years ago, the General Counsel of the Defense Department, Paul Ney, explicitly cited Lieber in opposing restrictions on explosive weapons in urban areas, saying winning as quickly as possible can support humanitarian considerations. Those humanitarian considerations, of course, are winning quickly. He even cited Lieber. This view has to be rejected. Another challenge to the norms was evident in Yemen, a war carried out by a partner and ally of the US. The Geneva Conventions have something to say about that. There's an obligation in the conventions to ensure respect for them. Although the phrase is somewhat opaque, at a minimum, as the ICRC persuasively explains, the requirement means ensuring that partners or proxies adhere to the conventions and they should not be supported. But the US and other major powers reject that obligation. Let me turn to the second and third problems now, the domestic and international issues. Lack of leadership is the biggest problem. In 2016, the UN Security Council, for the first time, adopted a resolution on protection of healthcare in war. It called on governments to reform domestic law. to review military rules of engagement, directives, and protocols on military operations, to protect hospitals from violence and search operations, to strengthen accountability and end impunity. Globally, it called for investigations and accountability, including referral to the International Criminal Court. The UN Secretary General elaborated on pages and pages of implementation recommendations. There's wide agreement that if adopted, these would have great potential to stop a lot of the violence against healthcare and war. But in the 5 years since, despite many affirmations of the commitments, there's been no follow-through. Political paralysis at the Security Council, lack of domestic leadership, military indifference to reviewing their protocols, and diplomatic obstacles to holding other nations to account all play a part. Still, the solution provides a blueprint for going forward, and we can make headway if that leadership arises. There are, in fact, some rays of hope. In the troubled Central African Republic, the site of a horrific civil war, the Minister of Health, Dr. Pierre Somse, has been outspoken on protection, calls out armed groups, negotiates with them, supports health workers. On one occasion, he personally interfered at the risk of his own life to prevent catastrophe. Here in the US, as well as in Britain, groups organized funding weapons in Yemen. In this country, at least, where President Biden has paused those sales. Most recently, Congressman Jim Govern, just up the road in Massachusetts, got a provision in the defense bill in December requiring the Pentagon to follow through in reviewing its operational rules. But the real point, it is up to us, to those who care about human suffering, especially human suffering in war, to be more active, to restore, to articulate the norms, demand adherence to them. It will take supreme effort to counter the forces of military necessity and the rationalizations for violence. But the cost and suffering and death are too great to try. I'll stop there and be happy to take questions. Thank you.
Len, thank you so much for that presentation. And I can say I very much look forward to reading your book when it becomes available. We have some great questions from the participants. And I would like to start with a question about the local level. It is, how can we begin to take action at the local level in some of these contexts to improve the security of aid and health workers, vice trying to have the United Nations or other large organizations push possible solutions from the top down?
That's a great question. Number one, a lot of the humanitarian groups are very good in reaching out to armed groups and conventional militaries. There's a lot of negotiation going on, and they're very good at it, a lot of them, the ICRC and MSF in particular, where they don't give up their principles, but they importantly negotiate security. A second dimension is that people in communities, as well as local health workers, are not without agency. They can use their voices, and they often do. In Afghanistan, elders are often responsible and take it upon themselves to negotiate with the Taliban and other armed groups. We don't see this. I talk about this some in my book, but it's very important, and probably on a kind of macro level, it has more impact than the top-down interventions.
Thank you. And building on that, we have a great second question, asking if you can elaborate more on positive examples of when IHL, public advocacy, or negotiation were successful in protecting access to healthcare.
Well, I've cited a few. I cited the arms sales in Yemen, the work of human rights reporting in Afghanistan. There has been the work I alluded to in the Central African Republic. There are other examples. Unfortunately, there are too many places like Syria where it would take a much greater effort to stop the abuses. But there's no shortage of examples. And in fact, in the DRC, one of the results of the violence was to change the way the Ebola response operated, to better engage communities, to really treat them as partners, not as objects of a response. So that was quite successful. It took way too many deaths to achieve it, but we do have examples. And we have examples too, where militaries have agreed to no weapons policies inside hospitals. So we don't have a shortage of examples where it can happen. The scale is inadequate.
Thank you. Turning now towards more of a technology-focused question, can you please offer your thoughts on so-called technological solutions that are out there in order to protect healthcare workers? One example that was offered was humanitarian notification systems, but even just speaking more broadly to the trend of using technology to improve healthcare worker security or access to healthcare.
There has been a lot of technology used in reporting incidents, apps for reporting. There's been a lot of sophisticated technology used, including social media, in reporting events. Unfortunately, though, I don't think there's a technological solution. You mentioned the deconfliction question. Deconfliction, for those who don't know, it's a weird word. It started from friendly fire, where it was a way to avoid soldiers hitting their own comrades. Now it's used as a way to identify protected institutions and buildings. And there's a list. In Yemen, there were 30,000 entries on the deconfliction list. It was tried in Syria as well. But in both cases, it completely failed because the perpetrators ignored the deconfliction lists. And I think that's an example where a technology as sophisticated as it is not sufficient. It's great at figuring out what's happening, but I don't think there are technological solutions. They're about norms and practice.
Excellent, thank you. And I think building on that, there was a question about the future of warfare. And like you said throughout your presentation, we've been looking at civil war, internal conflict, but there is a shift in discourse around a possible return to great power competition or great power conflict. And so the question was, thinking forward, if we are envisioning a scenario of great power conflict, what does protection of healthcare look like in that scenario? And what should militaries be doing now to embed protections in their operations planning or training?
It's a great question. I mean, one of the aspects of it, there are two incredibly important aspects of where warfare seems to be going. One is through proxy and partner warfare. I alluded to that with Yemen, but it's taking place all over the world. And I didn't speak too much about the duty to ensure respect, except at the end. But the problem is that the supporters of proxy or partner wars take very little responsibility for the conduct of their partners. They wash their hands, they'll provide training, they'll provide advice, but they take no responsibility for the acts. So that's a huge problem. The second, and this relates to the McGovern bill, that and the problem with urban warfare, as well as many other issues in war, that these conventional militaries that are committed to the Geneva Conventions, most Western militaries certainly are, they do not take the steps to change or adjust their military operations in the field to protect healthcare. It's not all that difficult, but if the future of war is more in the form of these proxy wars or even military operations against counterterrorism, they've got to change their operations to better conform with the requirements of precaution in war. And that's why it's not just the bad tyrannical regimes that are the problem.
Thank you. We've also had a few questions come in around asymmetric warfare and the use of civilians by armed actors, either state or non-state armed groups, in order to help offer almost a political protective shield is some phrasing that a participant used. So how can we either better advocate or address this issue of instrumentalizing civilians and also communities in conflict, but also ensuring that they're able to access healthcare and other needs that they require?
It's another great question. I wanted to make a couple of preliminary comments about asymmetrical warfare, given the question. There is a common mantra that the reason there is so much violence against civilians in healthcare now is because of asymmetrical warfare, that groups hide weapons in hospitals. They do what ISIS did and shoot from hospitals. In Gaza, Hamas was rightly accused of huge violations of the Geneva Conventions through these means. But it's not an excuse. It never has been that one side violates the rules, allows the other to. And in fact, the Israeli case shows that in a case of asymmetrical warfare, you can abide by the conventions and protect people if you're committed to do it. They were committed to do it back in the Intifada, the second Intifada. They weren't as committed to do it in the Gaza wars. So I think the fact that the nature of warfare may be changing does not excuse the harms. Now, how you restrain groups like ISIS or Hamas is a much tougher issue. They're not completely immune to political pressure, especially from within their own communities. But we have to acknowledge that those are tough cases. And it's even tougher for radical groups like Boko Haram in West Africa, where no one has figured out how to negotiate with them successfully or restrain them.
So as a final question, I think we cannot escape a presentation these days without thinking about COVID-19. And COVID has reminded us how important access to healthcare and health services are. So I would love for you to comment on the challenges to responding to the COVID-19 pandemic, and also the rollout of now vaccines that we have around the world within this context that you described to us today.
These have been great questions. It's a great audience. I really appreciate these questions. When I showed you the map at the beginning, and you can access that map through safeguardinghealth.org or insecurityinsight.org, I showed you the attacks on healthcare. If you pushed a button, you could see attacks in the concept of COVID, in the context of COVID. It also shows there were more than 400 acts of violence against COVID responders. And I think what we're learning is that, like in the DRC, but not quite as extreme, that the COVID has become so politicized that, and we see this in this country, of course, how even masks are a political issue, that violence can easily develop or be spawned by fear, by manipulation of information, and by political agendas. So we're seeing in a very different form some of the same characteristics that we saw in the DRC, which where the violence grew out of a war. So the COVID response reminds us that the risks of violence are very high, and that means we have to develop trust in health systems. We have to reach out to communities from the very start. There has to be consistent messages. There has to be responses to disinformation. It's not easy, as we're seeing, but it has to be addressed. So it is kind of a cousin of what I talked about today, and obviously a very serious problem, as the data shows.
Well, thank you very much. And with that, we are at time for today's event. Again, just thank you for taking the time to be with us here today, talk about your work and your forthcoming book. Very much look forward to reviewing it. And thank you for our participants for the great questions. We will have our next event on March 31st, when we'll host Sarah Petrin for a discussion on the root causes of humanitarian crises. So we hope that you'll all join us for that day as well. Thank you very much.